then a lot of times it's not what it's supposed to be. So why is that? Well, maybe when you were taking the transfer impression, you didn't get that transfer pin all the way down in the implant. Because you still can't tighten them, okay, even if it's not all the way in the hex. That throws everything off right there. And is the lab man responsible for that? He can't tell. He can't tell from the records you've sent him whether you did or you didn't get it all the way in, right, bro? They can't tell.
No.
Okay. And because of discrepancies like that, one major laboratory, you may have heard of them, Glidewell out in California, they would not do implant crown and bridge for over 5 years because they had so many remakes because of problems like that. And I thought to myself, there must be a way to control this more accurately. And the oral surgeon here, Dr. Clarizio, you may have heard of him up in Portsmouth, he does over 1,000 implants a year. Okay. He said, well, if you could torque it in and prep the abutment in the mouth, you'd never have to worry about that now, would you? I said, yeah, but you can't do that because you're going to burn the bone. And then you're going to have failures. And all of a sudden that thing is going to be twisting around in the bone and you could pull it out with your fingers. I could do a digital extraction. I don't want to do that. So what I thought about and with his encouragement developed, well, I love this monitor by the way. It's so clear. It's very nice. Now this is Marcia, and Marcia was missing number 13 for a while. Okay. Marcia did not have the Julia Roberts smile on. You didn't see that this was gone. But what happened was she was chewing mostly on her right side because of this, and you know what happens when they just chew on one side? They start breaking things. I said, Marcia, I told you this was going to happen. So finally she went for the implant. And this was done as a dual stage, and after the uncovering, here she is with the healing cap. And so I put in my transfer pin, and I take an impression. But I'm not going to send that impression to the lab. What I'm going to do is I'm going to put that transfer pin back into the impression that I took and put my implant analog on it. Now what am I going to do? No, I'm going to add more impression material so that that transfer pin is totally covered. And I'm going to do that in a way where I'm not impinging on the contact areas of the other teeth in the impression. That's very important. Because what this is going to give me is a soft tissue model. A very, very accurate soft tissue model. Okay? And you'll notice here that one thing I can't use my laser pointer. That's what I'm used to with a screen. But you can see here that
oh, that's right. You can't do it. Doesn't show up.
Right, it won't show. There's none of the impression material got on the contact points. That's very important because this is going to be provisionalized. And I need to have an accurate provisional. So, and here is my stock abutment. I'm not really happy, but this is all I have to work with here, with this system. I have to do a lot of prepping here on this. And if I had more variety and flexibility...
oh, there we go.
Ah, okay.
That's great.
All right. Okay. I feel like Harrison Ford. Okay, this is going to be handy. So this is a lot bigger than I want it to be, but this is what I had from the system. And so, I would rather have a lot more choices. It makes things a lot easier. But I didn't with that. That was 7 years ago. I hadn't met Ro yet. Okay, so I didn't have, so that I had to work with. And let me tell you, that took a lot of work to get that from that to there. But what I want you, I get to use it now. I want you to watch these soft tissue contours, okay? Because this taught me things over the years. So, from this point I hand it off to my assistant, and my assistant makes a provisional. Again, look at the soft tissue contours. Okay. So, now we go back to the mouth, and I torque this in for the last time. And we try in my provisional. And this part is so important because if I put that provisional in and the occlusion is correct and the contacts are correct, that tells me that every step up to then was right. I got the transfer pin all the way in. I got the model poured up right with the analog. I got everything right. It's not going to come back from the lab looking great on the model. Then you put it in the patient's mouth, and the margin is 3 millimeters off. So right there, I checked this out. It's fine. Okay. Then I took my impression, just like a regular crown and bridge impression. Okay, the laboratory gets this just like they would get an impression of a prepped natural tooth. So there's no trepidation on their end. They're not going to have to worry about, is this right or is this wrong? Do I have the components integrated correctly? Do I have them seated on the model correctly? All these things where errors can occur have been eliminated because they're getting an impression that's just like a crown and bridge impression. And my philosophy on implant restoration is this: get it as close to regular crown and bridge as you can. Get it as close to regular crown and bridge as you can. Now, 3 weeks later, this comes back, and we're starting to get a little bit more papillary invasion here, you might say. Remember what it looked like. So we're getting some tissue maturation there. I didn't realize this. I didn't realize what was going on here. And so this is the final result that I got. Okay? Better tissue contours than you saw in that soft tissue model, but not as good as they could have been. What is the mistake that I made here? I made a mistake here. What's the mistake?
You didn't use ankylose.
Number one. No, she's correct. Number one. Number two, what's another mistake I made here?
I think I would have flared the gingiva a little bit more, so that,
Waiting.
Mm-hmm.
Waiting.
Waiting.
Have the provisional in there longer, and that tissue will fill out
Grown, yeah.
as long as your contacts aren't too far away from the crestal bone. Okay? They will fill in. If you're more than, I think Tarno says, 5 millimeters from the crestal bone, then all of a sudden your chances go down. But if you've got them there 5 millimeters or shorter, it'll fill in if you give it the time, if you wait, if you have the patience. And explain that to the patient.
Waiting with the provisional?
With the provisional.
Why won't that continue with the final? What's the...
It may or it may not. And my point is that patients judge it from day one. Okay? Now, if this were an anterior and you put that in and there's the final, you say, oh, don't worry, give it a few more months and we'll be okay. You're going to get a lot of skeptical looks.
yeah.
There's going to be a lot of people who and I want this from day one to be right. And I'll show you how we get there. Because patients don't have the confidence in your knowledge the way you have it in your own knowledge.
No.
You know that, yes.
Having been a general practitioner for 10 years before becoming an endodontist,
Mm-hmm.
when you do good temporaries and you tell the patient, let's wait 2 or 3 months to see if the papilla grows. When I did crown and bridge, I had many patients that they never came back for the final.
Mm-hmm.
They said, this temporary looks great, why am I going to pay for the final?
Luckily, I really haven't had that problem, but I've heard of this before.
Mm-hmm.
And it's really important at the diagnosis appointment to discuss things like that.
Mm-hmm.
We're going to do this, we're going to wait this long, you're going to think this looks great, but let me tell you, it's not going to last you. Okay? Yeah, that's again laying the groundwork. And I haven't really had that problem, and that's probably because I spend so much time on it to begin with, but I've heard of other people. You're not the first one who's told me that. Yeah. Boy, that's a bummer, isn't it? That really is a bummer. So, same thing here. Here's a molar. Okay?
Your little pointer.
Okay. Now this isn't too bad. That's not good. In fact, you can actually see a little bit of the abutment right there. Okay. But again, this was.
Yeah.
We could use that for marshmallows, these things.
The marshmallow sticks.
So this was 13 years ago, and this was okay at the time.
Mm-hmm.
And I've heard, or back then, I don't hear it much anymore, but I have heard lecturers say, well, the soft tissue architecture on a molar really doesn't have to be what it is around an anterior tooth. And maybe that's true. I don't think it's true all the time, but I don't want to go for that standard. And I've done cases later, and this method now that I show you, I use routinely. Here it is, okay? Missing number 21. We get our transfer pin in. Then we get our prepared abutment. And here's the crown. And the gingiva is a little bit better here. And why is it a little bit better? Because I waited with that provisional, okay? But those tricks that you can do with provisionals and things like that aren't the whole deal. The system is too, and I'll show you that. See, I think it's better than that one, but not completely better. That's still a less than success. The last one I just showed you, it's still a less than success. And let's go for a molar. I did this 12 years ago. Transfer pins, abutments. All right, now there's a molar tooth that has a lot better gingival contour around it. Is it perfect? No, it's not, but it's better. And the reason that we have this triangle here, does anybody know why I have that triangle there? What can you see in this picture? You should show it to you. We were just talking about a doctor who talked about this. You know what the problem is there? Contact's way too high. Contact is way too high. And that's why.
It's more than 5
Oh,
millimeters.
yeah. So, especially with the angulation of that tooth.
Oh, the second molar, yeah.
Yeah, the second molar, because this was tipped forward somewhat. Okay, this is actually not a second molar, it's a third molar that came into that position.
Mhm.
Okay, and then you have that angular bone loss down here. So we're significantly
Then
more
you
than
got the
5
whole
millimeters.
cuff of
Yeah.
gingiva too, which
Mhm.
is tough.
Yep,
So,
so.
where was the mistake, in the provisionalization or the
This,
final
the mistake
restoration?
here was not being able to talk the patient into redoing the crown on that other molar.
Right.
Because I could have adjusted where the contact was and made this work that way. But no matter how long I leave these in the provisionals, this contact is just too high. It's just too high.
What about the contact point between the molar and the ovite? Would you have brought that lower to close the?
Yes, yes, I should have. That's absolutely correct. So like I said, this is better, but it's still less than success. And I like to show my failures and less than successes. And if you see someone speaking that shows everything is perfect, nobody's everything is perfect. Nobody's.
Mm.
Again, is it better than that? Yes, it is. But it's still less than success. Okay. Another very, very important technique for site preparation is the ovaponic technique. Has anybody heard of ovaponics? Okay.
Mhm.
These are very valuable tools. Very, very valuable tools for me. I did this in dentistry today about 7 years ago. That's when I still had the stash. I just got sick of it. I was spending 12, 15 minutes twice a week to trim it. I just said,